Hello, welcome friends. Today in this very special episode of Gender Equality Talks Live. Special because in hardly 2 weeks ahead of us, we will have the International Family Planning Conference happening in Thailand, as well as the world will be observing a very important event, which is the war to 2022, which is the global observance on antimicrobial against antimicrobial resistance. So we have Dr. Ishwar Gilada amongst us. Dr. Ishwar Gilada, as all of you know, is among the first medical doctors who began HIV care in the country in India when the first case got diagnosed. So he's the longest serving HIV medical expert. But more importantly, even before the first case got diagnosed of HIV in the country, Dr. Gilada was one of the very strong voices of reason and of medical conscience and ethics in the treatment of sexually transmitted infections, and especially in context of key populations like transgenders and or Hijra community in India, and a lot more. So let us listen to Dr. Ishwar Gilada. Just to remind you all, he's been elected again to the Governing Council of International AIDS Society, IAS, from Asia Pacific, and he heads the AIDS Society of India, as well as the Secretary General of Organized Medicine Academic Guild. Welcome, Dr. Ishwar Gilada.
Thank you, Paul.
Sir, we know that you are very busy, so let us straight dive into the issue. Please tell us, sir, have we really done enough to prevent the spread of sexually transmitted infections apart from HIV? Over to you, sir.
STD has been long neglected. I recall in 1987-88, when I looked at what is the budget allocation for STD, because that time there was no budget allocation for HIV in India, and that was 33 lakhs rupees, which is in Thai language half of that, that is 16 lakh or 1600,000 Thai baht for the entire country. And that time the country's population was around 110 crore, or we can say 1100 million. So it was very, very neglected topic. Secondly, the post-graduation in STD has been clubbed with skin. And when you talk about postgraduate in skin and STD, that means people are more interested in skin, where there is a lot of money available for skin in private practice, because they can do laser and a lot of cosmetic treatment. And unfortunately, people do not want to pay for emergencies. People do not want to pay for some kind of good treatment, but they can pay for cosmetics. For looking better, they can pay in millions. So a lot of doctors who are in this field of skin and STD, which are combined specialty, they neglect STD because they don't get much in STD. And thirdly, STD was mainly a problem for a developing country like India and entire Africa. And there has been always two worlds. One is there and one is ours. And people who were doing research and any kind of development, they were mainly white people, mainly in the north of the world. And they thought that Africans are kind of substandard people. So they develop only syndromic management of STIs. And I think that syndromic management is a culprit of developing antimicrobial resistance in Africa and almost every place where they have been doing syndromic management. So that is the reason that STD has been neglected, both by the medical community and the governments, where they did not put much of budget, and everything depends on budget. If there is no budget, nobody is going to look after STD.
Yes, sir, totally. And sir, now coming to an interesting part, please help us understand the link between antimicrobial resistance and STDs. So is antimicrobial resistance posing a problem? Like are STDs becoming untreatable, difficult to treat? How big is the problem, sir?
Firstly, let us understand, when you are managing STD, how do we reach at a diagnosis? By and large, STDs are in three groups. One which are to be found in blood, and one which are to be found in the genital area. So these are two broad groups. What we can find in blood is HIV, hepatitis C, hepatitis B, and syphilis. And all others are indirect way, like we can find antibodies to HSV or herpes, antibodies to CME, but they are indirect. But directly we can find only these four. All others, what we can find, there are broadly 20 STIs. So other 16 STIs plus syphilis can be seen also in the other group. So there we are subdividing them into three groups. Number one, ulcer. So ulcer is like a wound, and it can be a small, it can be big, it can be painful or painless, it can be single or multiple, or it can be good looking or dirty looking. So you'll say, how is a good looking wound? Yes, good looking means is a red, beefy red, and when you touch it comes the blood. But when you talk about dirty wound, it smells, foul smelling. It looks with a dirty granulation tissue. It can be gray color, or white color, or yellow color granulation tissue, or green color granulation tissue. The second group is of discharge, urethral discharge. And that discharge can be again into four different types. One is a sticky, colorless, one can be white, one can be green, and one can be yellow. And depending on that, we can subcategorize whether it could be gonococcal, it could be chlamydia, it could be candida. So we can subcategorize, but it is very difficult to subcategorize only based on the color. The third group is of that of growth, and the growth can be cauliflower-like growth, which is wart, or it can be skin tags, or it can be what you call pearl-like growth with the central dimpling, that is molluscum. And molluscum is caused by the virus which is from the same family which is causing monkeypox. So is a molluscum virus. Third is a blister. Blister come either one, but mostly it is coming in groups, and they come on a burning skin, and that is herpes. So broadly they are divided like that. So when you divide broadly, then you can reach at some kind of conclusion where the test is required. For example, if you see a blister which is burning, and there's a history of all these are happening in the 90 days after exposure. So it can happen in 9 days, it can happen in 90 days, it can happen in 1 or 2 days also, like gonorrhea or chlamydia. So when you categorize them, then it becomes like syndromic management. A person has a discharge, you treat them as chlamydia as well as gonorrhea, you give X antibiotic, and patient will heal, may not heal, come back again, you go to second level. Similarly for ulcer, an ulcer can be because of syphilis, it can be because of chancroid, it can be because of donovanosis, or which is called granuloma inguinale, it can be because of herpes. So there are n number of ulcers there. Again, by and large, you manage symptomatically, and that is a syndromically. But when the investigations are available, when you can train people, I don't think it is difficult to even train African people. So what has happened basically, as I told in the beginning, that people in the northern part of the world, they consider Africans or people from the developing countries as subhuman beings, and they said that they don't have brain, they don't understand, so they never taught them. When I went to Africa, when I did training, even for HIV, they said, sir, we have been told it is not your cup of tea. I said, no, it is not. It is your cup of tea. It is my cup of tea. And I have a South-South collaboration in my mind and my behavior. I will teach you how to manage HIV, how to manage STI. And I trained them. And at the end of the training program, some of them really wept. They said, sir, you are treating us as a doctor. I said, if you have an MBBS degree, you are a doctor. Whether you are a doctor from South or North or Africa or America, it doesn't matter. You have a basic degree, I will teach you. And they said, sir, these people from so-called developed countries, they never treated us as equal. When they came here for some research projects, etc., they asked her to sit there and then write prescription, write this, explain to the patient. But they never allowed us to do anything. So if you treat them as subhuman being, then you cannot expect them to work at par with you. So treat them, train them, and then you can diagnose cases. Most important is history taking. Second is examination or inspection. So you do inspection, you do examination, and find out what kind of ulcer it is, whether it is a nodular, it is soft or superficial or deep. You can make out, and then you do investigations. It is okay that when the investigations were not well developed, CBNet was not available, PCR techniques were not available, or ground glass microscopy is not available. So at that time, syndromic management, giving treatment is cheaper than diagnosing. It's okay. But now we are in 2022. So at this time also, if we consider the same prevailing scenario which was there 40 years back, 35 years back, we are making a big mistake. So we should develop some kind of techniques and cheaper diagnostic techniques. So I have been suggesting always to some pharma companies that why can't you make a 3-in-1 test, which can be used for in blood banks or in STI clinics. So, for example, one test should tell whether that person is STI positive or not. In that, we can have only 3 or 4 tests. And then if it is positive, then we can give subcategories. So in a one single blood, you can find out whether the person is HIV positive or hepatitis B positive or hepatitis C positive or syphilis positive. Or if that says only STD positive, then you can subcategorize. So I think we should develop such kind of techniques where we can diagnose easily at low cost. And with this CB-NAT technique and PCR technique or technology and indirect tests which are available, I think we can come to fairly diagnosis of STIs and then treat them appropriately. By not doing that, what we have done, we created a lot of resistance. Firstly, we are not diagnosing. Secondly, we are not preventing well, because after the PrEP has come, pre-exposure prophylaxis for prevention of HIV, we have been telling PrEP has come, it can prevent you from HIV, but it doesn't prevent you from STIs. And PrEP is not replacement of condom. Condom prevents you from 20-21 STIs, but PrEP will prevent you only from one infection. So PrEP has to be used in addition to barrier protection like condom, whether it's male condom or female condom. But that has been not well emphasized. And therefore, STIs are increasing. And because of the explanation I gave you earlier, they are not only increasing, there are STIs which are resistant in the first place, which is the primary resistance.
So sorry, sir. Yeah. So, sir, I know you are short on time, but can you just please help us understand how drug resistance is affecting HIV, the progress we are making in HIV sphere? Yeah.
See, in HIV also, there are very few well-trained doctors who are practicing full-time HIV, whether it is India or in many other countries. So, but doctor by birth, by what you call temperament, will not say he doesn't know or she doesn't know. So when the patient comes, so I have HIV, I'll manage. Maybe he will ask the patient to sit outside and go and Google around and find what are the treatments available. So there are n number of doctors who have been treating HIV patient with one drug or two drug or same old drugs which are already been registered or patients have been registered. Secondly, we created a man-made resistance in HIV patient by using nevirapine, single dose nevirapine for prevention of mother to child transmission. And from the very beginning, we have been saying that please do not use that drug as a single drug. It has been causing a lot of resistance. And with the just single drug also, a resistance to the level of 50 to 70% has been caused to nevirapine. And resistance to nevirapine is not only to nevirapine, it is also to the group, which is what you call group with the efavirenz and with nevirapine and with the rilpivirine. So when you are causing the resistance of 3 drugs just because of using one tablet, it has been a great harm has been done to that class of antiretroviral drug. And then there were medicines which were like AZT or 3TC. Fortunately, there is there may be resistance to 3TC or lamivudine, but even with that resistance, you can still use that drug, and that is a wonder drug. But other drugs which are already resistant, they have a drug resistance at that particular resistance, and they also have a class resistance. So class resistance can be in a group of 3-4 drugs, and it can be 1 drug or 2 drugs. So that class resistance. So we cause resistance by inadvertent use of or knowingly using of a single drug nevirapine. Number 2, what you call just a kind of a irrational treatment of HIV patients without understanding. And thirdly, because of the or positioning that in US and in Europe, they do a drug resistance test or DST test before they start the ART. So they can use the drugs which are going to work. But in a country like India or Thailand or any of the developing countries, we are using a deductive logic, and we are using a new drug which is supposed to be non-resistant. Almost 99% people it is sensitive, though there has been now cases that there is also resistance being developing to dolutegravir. So once these newer drugs have come, then drug resistance has been taken care of properly. But there are a lot of medicines in ART or antiretroviral where they have a transmitted drug resistance or primary drug resistance, and that can be from 5 to 10%. So it has been saying or international understanding in science that if transmitted drug resistance is more than 5 to 10%, then either you should do drug resistance testing or you should use integrase inhibitor based regimen, which is either raltegravir or dolutegravir or bictegravir. And fortunately, with the WHO dictum as well as the understanding of the Western countries' experience, a lot of people have started this dolutegravir based regimen because that is available as a 3-in-1 regimen or a single tablet regimen. And for that also, we must salute Indian pharma companies that they are able to give this 3-in-1 combination at 1 to 2% of international cost. And today, whether it is a dolutegravir based regimen or other regimen, more millions of people have been saved than they have died only because of intervention of India and Indian pharma companies.
Thank you, sir. Sir, you have already indicated on the prevention of antimicrobial resistance and the use of rational drugs. Is there anything more we would like to add on how to curb antimicrobial resistance in context of STDs and HIV?
So I think we should do because we cannot always blame patients. We cannot always blame authorities. We cannot always blame those which are making guidelines. We should train medical caregivers properly. Both by way of formal training and by way of up-to-date knowledge. So whenever some new thing comes, like even today also we see prescriptions of AZT being used, we see prescription of nevirapine being used, we see the prescription which are using outdated drugs or they are using 2-3 different drugs. So I think this kind of practice should stop. And rather than making it stop, we train. If we find out that we have some, say, 100 such odd prescriptions, you catch hold of those doctors and say that we are doing a program for training you, and probably they would be interested. 70-80% of them will be interested. So train them, and after you are done them, and despite that something is happening, then you start taking action against them. Because if a medical caregiver is creating a resistance, I think that is the worst thing to happen anywhere. And secondly, we should do a proper diagnosis. We should use those drugs which are either robust like a dolutegravir or darunavir, which are resistance proof. Maybe 1 to 2% resistance is there, but by and large they are resistance proof. And then we add a backbone. And we should also look at, can rather than 3-drug regimen, 2-drug regimen can be there. And there's a single tablet available for 2 drugs like dolutegravir and lamivudine. So I think we should spend more time in such thing where rather than 3 drug, can 2 drug be used? Rather than older drug, can newer drug be used? Can there be different combination? So I think by doing that, we can prevent both in HIV and similarly in STI. And lastly, if that is not done, then we are going to face a problem of both primary resistance and secondary resistance. Primary because it is already primary, it is transmitted drug resistance. We have not done any drug resistance testing. We kept on using that drug along with another drug, and because that was if suppose out of 3 drugs, 2 drugs are resistant and you are using 1 drug which is potent, even that potent drug will become important after a couple of months or a couple of years time. So we have created that resistance and that should be stopped.
Right. Thank you, sir. And finally, your message for the upcoming International Family Planning Conference. And sorry, and as well as the World Antimicrobial Awareness Week. Thank you.
So you see, this Family Planning International Conference, which is happening later this month, and Antimicrobial Resistance Week, which is organized and celebrated and observed by WHO, they are very important events. Now, usually when we talk about STIs, they are either diagnosed by STI specialist or diagnosed by family planning or gynecologist or women specialist. Because most of the women, they do not go to STD specialist. They go to gynecologist, where while examination they find something and then diagnosis is made. And not only that, by doing a pap smear, they can prevent a lot of papilloma virus infections. It can also cause cervical cancer. So by looking at these issues, the family planning program should become robust. They should encompass little bit training and update on STIs, also encompass how STIs can be best managed and best treated, how to prevent resistance, and also look at a comprehensive health as a package rather than only. And I think the entire goal or principle behind family planning or family welfare was a comprehensive health. It was never to just restrict birth of children. So that was a wrong concept, if at all. But so in India, rather than family planning, they call family welfare, and that means a comprehensive healthcare. So and lastly, condom use has been only propagated after HIV threat came in. So when we started condom promotion in, I think in large quantities, it was around 89, and in the red light area, we could not distribute more than 5 condoms. And within couple of months' time, maybe years' time, there was a stampede to get condom. Why? Because they realized that by using condom, they were not getting STIs. By not getting STIs, they were not going to doctors. They were not spending on their healthcare, and they are able to save even in sex workers. So if that could have been done properly by family planning department, we could have prevented a lot of STIs, which was not done. So, and because mostly, and family planning department program or at the top level was run by male, and they were saying, oh, utilize this for female, and they never emphasized that male should use condom. So it was always vasectomy versus tubectomy. It was 95% by 5%, 95% tubectomy, hardly 5% vasectomies. And same thing, you want to get any STI or pregnancy, you do coitus interruptus, you do other techniques, but I'm not going to use anything because I do not enjoy with condom. So that attitude was changed only after the STI came in. So now at least emphasize properly both male and female condom usage, which are good barrier protection. They protect almost 20-21 STIs, not merely HIV, and also promote hepatitis B vaccine, which is not done. And just like antimicrobial resistance going to be a big pandemic in the globe, is going to be a bigger pandemic than HIV of hepatitis B. And it is a vaccine preventable infection. It is 10% prevented through a couple of maybe just $2 or something. $1 you can get one vaccine. India is a vaccine capital of the world and can provide vaccination all over the world. So promote hepatitis B vaccination both amongst your doctor community and all your patients. So they should be all protected, because once you take 3 doses, you are protected for entire life. You don't need to revaccinate. I think if that is done, that will be a greatest service your family planning community could have done to the globe. Thank you.
Thank you so much, sir. Very important message on comprehensive health, as well as thank you for mentioning hepatitis B as well. And that is a very missed opportunity, a huge missed opportunity. And let us hope that with just 97 months left for sustainable development goals, and global health security is so integral to that, Dr. Gilada's message on hepatitis B will not be missed by the policymakers worldwide. Thank you again, sir, and all the best for today and beyond. Thank you. All the best. Thanks.